Hey everyone, welcome to Pain Consultants USA first podcast. Today I'm here with Dr. Bonner, and we're going to be talking about some challenges that we see for people who live in chronic pain and the management of their pain in the current healthcare landscape. How you doing today, Dr.
Great,
Bonner?
thank you. How are you?
Not too bad. Okay, let's get right into it. The first issue that I see is the number of people and the growing concerns of chronic pain in the United States. There's stats out there that there's over 100 million people living with chronic pain. Depending on how you define it, somewhere between 3 to 6 months of living with pain, you fall into that category. So I'd say 3 months is a little short, but if we're up to 6 months, people living with chronic pain, there's quite a few individuals out there. The number one cause, of course, is people living with back and spine related issues and pain. And I think that's what your primary practice is. Is that correct, Dr. Bonner?
Yeah, I think definitely. I mean, most people I see are probably low back pain, the most common complaint, and then some of the major joints like hips and knees, and a lot of shoulder pain, and then a reasonable amount of neck pain as well. So a lot of spine-related pain. I agree with you that 3 months seems a little bit short, especially when you hear some people talk about really natural tissue healing time as something more along the lines of a year to 2 years. So some of these people, we may expect them to have the problem that they have for a long period of time, and then may eventually resolve on its own. But yeah, it's definitely a concern that more and more people are dealing with this issue, and I guess part of the reason why we're here is because we don't think that a lot of the current treatments deal with the issue very well.
You're absolutely right. And I think you bring up a good point as far as natural tissue healing. And we probably do a disservice to the patients with our definition because, 6 months is very, very quick, especially when you talk spine related issues. I mean, there's been studies out there that, herniated discs in individuals, whether they have surgery, injections, conservative care, physical therapy, or do nothing, sometimes out as far as 2 years, they outcomes are pretty similar. So that's something that we should probably take into consideration too, the type of injury and normal healing, because 6 months is very very quick for spine related
It's
issues.
something that I talk to patients about every day because I think a lot of patients don't comprehend that it may take a while for them to get better. They want the part of the problem is patients always want a quick fix for the problem, and sometimes that quick fix isn't there. Sometimes we need to expect that it's going to take a while. Part of that being, part of that discussion is usually that this injury is developed over a long period of time, so there's no reason to expect that it will heal very quickly. A lot of these injuries that we deal with are kind of like what we would call repetitive overuse injuries, and so the injury wasn't, although the patient may have felt it with like one specific event where the pain really started getting much worse, it's usually something that's developed over a long period of time, slowly accumulating more and more injury to the tissue, and then eventually the pain really starts. And so we need significant time to heal the injury that was created. And so explaining that to them often helps them understand that it is going to take a long period of time to get better.
Yeah, I would agree with that. Setting expectations kind of upfront. I mean, I don't blame patients for wanting to feel better quicker. We've all been in that
Yeah.
boat, but realistically, I mean, oftentimes although you feel pain for a lot of these conditions, it doesn't mean there's more tissue damage going on. It's more that it sucks that it hurts,
Right.
but with time and proper treatment, we can often, get through that, and slowly, gradually, over the course of months and even years, you kind of get back to your normal activity, even if, you avoiding surgery, medications, or different types of
Yeah.
procedures.
I find that patients are generally pretty accepting of that idea too if you explain it to them. I feel like we all get a lot of patients who have been in pain for a long time, and they come to you very frustrated because they've been getting treatments that haven't been working, and they want to get back to work or get back to living the life that they used to live. And they come in very frustrated and they say, I need to get better as soon as possible. I need to do this. I need to do that. And, I try to slow them down from the start and say, look, I'm just meeting you for the first time. It's not a reasonable expectation that you're going to get better very quickly. There's very low likelihood, if you've had pain for more than a year, that I'm going to make it go away all of a sudden. In some cases, it is possible, but in most cases, that's probably not a reasonable expectation. Then, if you set them with the right expectations, they often say, okay, and then they're willing to kind of go along with the treatment program. And I think that gives them a better idea that, we're looking for more of a slow, progressive improvement than like a golden bullet that's just gonna end the pain immediately.
Yeah, I think some of those frustrations stem from, the medical care they receive leading up to our evaluation, right? So we think about the natural progression or flow through the medical system, right? Most people say they have back pain or neck pain. They either see their family physician, who either are going to refer them to therapy and more of a generalized referral to therapy, which isn't the fault of a family physician. That's, that musculoskeletal care isn't necessarily their specialty. Or the patients will go directly to a therapist who does a good job, but, the exact diagnosis might not be there. At least in my experience, I usually see patients. Patients have seen usually three different providers before they get to me. Family doctor, an orthopedic specialist, right? So those are surgeons who are being asked to evaluate these patients at time of injury onset. And again, if they're not a surgical candidate, I mean, these probably aren't the exact specialists that patients should be seeing initially.
Yeah. Yeah, I mean, I think that's part of the problem sometimes is it takes a while for the patient to get to the right person to treat them. And that's part of another reason why we're here today. This uh, we hope that with the telemedicine we can get access to more patients, quicker. If we're closer to onset of injury, we can help them get the right treatment quicker, which should help decrease the rate of development of chronic pain. And I think that's been studied that, the longer it takes to get someone better, the more likely they are to kind of persist with that problem. And there's many reasons for that. Obviously, the tissue doesn't heal correctly, and then other central nervous system parts of pain sensation that kind of start echoing, and then they really can't get rid of that sensation.
Yeah, I would agree with that. And I would even add in, the more and more we do this, I see, the attitude, pain wears on
Yeah.
you, both physically and mentally. And I mean, some people are just exhausted with everything they've been dealing with, and, it wears them down. And then if you aren't in a good place mentally with regards to your pain, I mean, there's no chance conservative care or most treatments are gonna
Yeah.
are gonna are gonna provide you with enough relief.
Yeah,
I
and
mean, so it becomes a mental struggle sometimes.
exactly. And I think we know the high rates of comorbid depression with chronic pain, and it puts the patients in a tough spot because there's a lot of prejudgment of these types of patients sometimes when they come in and they're extremely depressed, and someone might tell them that their pain is related to their mental state and their depression, and they need to fix the depression. And granted, that can definitely help, but there's many patients probably who the depression is secondary to the effects of the pain. And if we can treat the pain, the depression will get better as a result of that.
I agree. I agree. I think it all comes back to patient education, um, right from the beginning, which is probably one thing that I feel like our medical field has probably gotten away from a little bit. We were probably better at it even before our time,
Yeah.
but we always think of physicians as educators, and right now with the hustle and bustle of the way healthcare is delivered. I think that is probably lost quite a bit, unfortunately.
Yeah, I mean, of course, in a world where you get paid for the procedures and the interventions that you do, you're just more likely, regardless of whether or not you're thinking about it, to tend to do more of those procedures because it's more beneficial for your business in the long run. And so, if you're doing that, it takes away from the time that you might need to educate a patient. So we need to kind of rethink how we can educate patients. We have the internet, which is just loaded with information, and sometimes it's hard to find good information. But I think it's another point of why we're here is we're going to try to educate patients so that they can help get themselves better. Because if I always find if a patient is well educated on their condition, they can really figure out how to manage the problem. Even if we can't make it go away, they can always figure out how to manage it long term so that they can live the way that they need to.
Yeah, I completely agree with that. I mean, it highlights a couple, I don't not so easy fixes with the medical field in general. I know there's a lot of talk around, certain fixes, depending on if you where you fall along the political spectrum, which we're not going to get into, but overutilization is definitely a big thing. And, it's not just with, different injections or procedures for spine related care, but also medications and even physical therapy, right? I mean, we both are strong believers in a physical medicine approach to treatment of a lot of chronic pain issues, but there definitely is overutilization of these resources as well.
Yeah, I think we were just discussing uh, before we were starting recording about the overutilization of pain medications and how that sometimes puts patients in a bad spot. Medication prescribing is very difficult because every patient reacts differently to medications. And so we need to kind of evaluate that very closely on a case by case basis and adjust it accordingly. And sometimes you find people that are on a regimen that just isn't reasonable and really is doing more negative effects than positive effects for them. So, we need to be very careful about what we prescribe, how we prescribe it, and how the patient is tolerating medications and if they're getting any benefit from it. Um, and especially when it comes to opioids, which I think you were just kind of mentioning.
Yeah, I mean, if you break down just medications for a second into, primarily opioid versus non-opioid meds, right? I mean, the state of medicine right now, everybody hears this evidence-based practices or evidence-based medicine, and yeah, it's coming to the light now that there really isn't much evidence to support opioid use beyond 12 weeks, right? There's no great studies out there. And we know there's a role for people who live with chronic pain, but we don't, as physicians or healthcare providers, we don't know how to identify who's best or who will do best with those medications on a chronic basis. So, there's still a steep learning curve that has to occur there. In the meantime, unfortunately, now we're dealing with the worst opioid epidemic our country's ever seen, and that's for a whole host of reasons. And then you brought up, something, or you hinted at something called opioid-induced hyperalgesia, right? So we're learning that people who are on long-term pain medications, usually at higher doses, but doesn't have to be necessarily extremely high doses, could actually be making their pain worse, which we never thought of before. And it's hard to convince some patients of that, but I've seen that firsthand many
Yeah, and it's
times.
devastating when it happens. I mean, I remember doing a procedure on one patient in particular who had that, and like the amount of pain this guy had from just the injection of local anesthetic was like through the roof. He could barely even tolerate that. It was jumping off the table, and it was likely all related to opioids that he had been taking for a long time. And it's a tough complication to deal with, and definitely doesn't make sense to a lot of people. I'm sure it's a topic that we'll talk more about in the future for sure.
Oh yeah. Yeah. And then like, briefly about the non-opioids, right? I mean, there's tons of options out there. People see commercials on TV all the time. And when you look at some of those studies, right, they compare it to placebo. So yeah, sometimes what they define as a clinically or statistically significant result is on a score of 0 to 10 pain scale, a decrease of 2, right? I mean, we could argue all day if that's actually clinically significant.
Yeah.
But again, when we start looking at the evidence for some of these things that we prescribe, I prescribe them, it really should be kind of case by case basis. And we have to remember that these things don't come without potential side effects either. A lot of these non opioid medications, I mean, there's weight gain, there's, I mean, depression even,
For sure.
or different other side effects we have to be aware of.
I'm mostly treating a geriatric population at this time, and it's often very difficult to find medications that they don't have side effects from. So, a lot of times the classic non-steroidal anti-inflammatories that everyone takes, ibuprofen, Advil, etc. These patients really can't tolerate that kind of medication because they have kidney dysfunction or a stomach issue or have a history of a bleeding ulcer or something. And so, uh, it's always difficult to find medications that work and work in combination for a patient.
Yeah, exactly. I think that brings us back to, our kind of primary tenet is really focusing on exercise as a form of medicine, which I think, everybody's gotten away from.
Yeah.
Uh, Less is more sometimes.
Yeah, I agree. I think exercise is probably one of the hardest things to talk about with patients because everybody knows that exercise is better in general, but how to exercise, which exercises to do or not do if you have a certain problem or don't have a certain problem, that can change your exercise program significantly. And so, and the other thing is that people just don't exercise. They don't like to exercise. It's hard work. So, there's a lot of issues with trying to prescribe exercise. And again, it comes back to patient education, right? You have to educate the patient on why exercise is the treatment for the specific problem that we're discussing. And a lot of the problems that we deal with, exercise really is the number one treatment option if it is prescribed correctly. Um, but again, you get, like you mentioned previously, you get a lot of generic exercise programs prescribed. They could be causing more harm than benefit, and so that's where it takes evaluation by a good physician or physical therapist to see if that's the case and really alter the program appropriately.
Yeah, and that hits on my next question as far as we hear this every day, but what do you tell patients when you want to send them to therapy and they say, "Oh, I already tried that," or it caused more pain?
Right. Um, that's where I always tell them, I say, well, what did you do last time? Tell me about exactly what you did. What kind of exercises? What were they doing with you? And then, okay, was it one thing in particular that really hurt or made you feel worse? Or was it everything that you did? Or was it the next day that you felt worse? Sometimes I find that some patients never really exercised before in their life, and they don't understand the concept that sometimes exercise will make you sore the next day or the next 5 days, and uh, and that needs explaining sometimes. Other times it's one specific exercise, and it might be because that exercise really isn't indicated for their condition, and so we can talk with the therapist or with the patient about avoiding that exercise or similar exercises. Um, and and tailoring the program so that it's not causing a problem for them. And then sometimes you have patients that are in so much pain that really it's not even so much exercise that will be okay for them because everything hurts. You just need to find like a comfortable position, and maybe starting with finding a comfortable position is a good start to therapy. You don't even have to do any exercises. The therapy is getting into a comfortable position and being able to maintain that position, and then moving on slowly from there. Some of these programs need to be very much kind of toned down so that the patient can tolerate it and then slowly progress, because a lot of patients will quit, like you said. If it starts to hurt, they'll say I'm not doing this anymore, and not give it the chance that it needs when someone can alter the program based on the response to the program.
Yeah, and I think that's our role, right? That's where we fit in here, with inaccurate diagnosis or non-specific, diagnosis. You get non-specific treatment, right? So, I mean, every day I see patients that come into who have back and some right lateral or right outer thigh pain that they describe as tightness, and they've been going to therapy for an IT band issue where really it's coming from the back, and
Yeah.
some of the exercises they've been doing have actually been aggravating their back. And it's no fault to the patient or the therapist, but they didn't have an accurate
Yeah.
diagnosis
Yeah.
initially. So some people get concerned, oh, how can you do this, via
Yeah.
telemedicine, right? I mean, but we're trained to deal with these types of conditions, so we obviously are looking out for them. They're kind of in our mind when we're talking with
Yeah.
patients, right? Obtaining a great history, and then most patients can do a physician-led physical examination on their own,
Right.
and we can diagnose with pretty good accuracy, at least where to
Yeah.
start. Whether it's imaging or therapy.
I think that most uh, physicians who do what we do would probably agree that within a minute of talking to the patient, you at least have a few things in mind that you think could be the likely causes of the pain. And sometimes the treatments for those things are very similar, and so it sometimes you don't even have to find the exact thing, but if you know the possible etiologies of the pain, then you could say, okay, well, if it's this, this should help, and if it's this, this should help, because this kind of pain only comes from two or three different things typically, most commonly. And I think that we have a good idea of what the common causes of pain are, from in the body, really. And so where the pain is really helps us determine um, what could be causing it, and then we can also narrow it down by asking questions about what makes it worse, what makes it better, is there associated symptoms like numbness and tingling and other things. And even if we can't get the exact diagnosis, we can still really target a specific treatment to help the patient get better.
Yeah, I think pattern recognition is a big thing with
Right.
what we do. Um, but we have to, you have to have the knowledge and understanding of what to be looking for to be able to pick up on some of those
Yeah.
patterns. And that brings us to another point that we were discussing earlier, as far as one of the barriers that we see to patients getting appropriate treatment is just access to skilled providers.
Yeah.
You know, um, there's a lot of providers out there to be spine, musculoskeletal, pain, movement specialists, but the more we do this, the sometimes the stuff we see, it's a little scary out there. What patients are really putting their trust into and relying on some of these providers, and in my opinion, they're not getting proper
Yeah, I
care.
mean, we all see our fair share of patients who have been to other providers, and you get the either the notes or the story from the patient, and you wonder what's been happening, because they've been getting kind of the wrong treatment all along. And once you get them in the right treatment program, they get better, like they should get better. So that's extremely important. And telemedicine is a great way to improve access for everyone. If you have as long as the physician is licensed in the state that the patient is in, the physician can see the patient, and no matter the location of the physician. So that's great for patients who either live in rural areas where there may not be any specialists in their area, or where there may be
Yeah.
limited access to specialists. And then telemedicine is going to allow them to really kind of see people all over the country who may be able to offer a different opinion than the opinion that they've had already, which is what patients need sometimes. Sometimes they need a different opinion of their situation.
Yeah, always sometimes a second set of eyes
For
is all
sure.
you need. And I think it's more convenient for the patient too,
Definitely.
right? They're busy. Uh, work schedules. I think I just read something that I forget the exact amount of money or days that were left on the table, but it seems like Americans aren't for vacation. They're working harder. They're working overtime. They're losing out on vacation time. So I know it's tough for patients to actually get to doctors' offices, and then most practices, patients
Yeah.
will be waiting a while to see the doctor. So they're losing out on a couple hours of productivity and probably pay.
Yeah.
So this, I
For
mean, you could do at
telemedicine.
lunchtime.
Yep. Yeah, exactly. You could do it at your coffee break, or any time. Take a little break at home, and you don't have to drive anywhere. You don't have to sit in traffic. You don't have to pay for parking at the hospital, anything like that. You can just do it from the comfort of your home on your computer or on your phone, and just makes things a lot easier for patients. And like we've talked about, it just really allows patients to regain control of their care, which is where we need to allow patients to have that control, because that's what really creates patient-centered care. And that's what the value-based care movement is all about: patient-centered care. We need to do the right things for the patient, while doing it efficiently.
I completely agree with that. And these are, I think, a telemedicine is the modern day house call,
Yeah.
right? Kind of, it's all coming back now. We're just using technology to our advantage finally.
Exactly. Yeah, you're definitely right. I mean, my grandfather was a physician. He was doing house calls all the time, every night, weekends, and everything. And then my dad was a physician, and his practice was probably the mostly the opposite of that. He certainly made a few house calls here and there for friends, but generally he was, in his office seeing patients, 9 to 5 or 9 to 7. And now it's coming back around where we can get the access of the patient at home, but we don't have to be at the home to take care of them. We can the physician can be anywhere else, and get a similar evaluation of the patient.
Yeah, I think this will put accountability back on providers too, right? So if if patients have access to high quality specialists, no matter where they live, um, they can get second opinions. They can for spine related issues, right? If they've had injections or procedures done on their low back or neck, they can get the images from their treating provider. They can get the report. They could send it to us or someone like us and get it reviewed. Was the procedure done accurately? Was the indication correct? Did they use the right medicine? Did what they said, was that what they actually did? It's scary, but I've seen where you know people who get procedures done by physicians they trust, sometimes they're not the correct procedure, or they're not performed properly.
Yeah, I mean, there's certainly all levels of degrees of that. I don't know if you listened to I think it was the Doctor Death podcast, but that was an
No.
extreme example. But it was a neurosurgeon who certainly didn't have the training that he should have had, and he was, doing surgeries, I believe, in Texas, and the surgeries were just not even close to correct. And he unfortunately severely injured or and killed multiple patients until he was finally stopped. But um, it's just it's I mean that's an extreme example, but you can find all degrees of examples to lesser extents where maybe a patient just had a procedure and the needle wasn't quite placed where it should have been, and so maybe that's why they didn't have a response. And that's that can be very important for patients in pain. And so it's just another benefit of telemedicine is you can upload the images right to the website, take a look, and have a consultation about it.
Yeah, I mean, talking exactly about maybe the more kind of relevant issues, right? So you mentioned medication. If people with sciatica or herniated disc and they have a lot of leg pain, they go for an epidural. I've unfortunately seen plenty of times where you look at the pictures and the needle and the X-ray dye, which is used to make sure the medicine's going in the right place, is in the middle of nowhere. It's not even close to the nerve, and that's the equivalent of just sticking a needle in your muscle and injecting medicine in the office, right?
Right.
There's no difference.
Right.
But patients are given the false hope that this is going to help,
Yeah.
even though the provider is not doing them a service.
Right.
Similarly with radio frequency ablations, right, where you heat up and burn the little nerves that go to the joints of the back. You see it plenty of times that the actual needle size just isn't big enough, right? We talked about evidence-based medicine. There's studies that, if you're using a small gauge needle, I mean, the treatment is not going to be effective. Outcomes are not going to be what you want compared to if you use the appropriate larger gauge needle, which is described in literature as far as the standard of care. Outcomes can be much different.
Yeah. Yeah. I mean, it just more and more we know that these treatments need to be done correctly or else they don't work. And the other thing that comes with that is sometimes the studies that are done, they may not show a benefit of the treatment, but it may be because the treatment wasn't done correctly. So that's a battle that we see constantly being fought in our pain management world. And and uh, and I'm sure we'll continue to fight that battle. And so, creating more access to more high quality specialists is great for patients because they will have more options. And yeah, that's what we're here for.
Yeah, I mean, along the lines of access with regards to consolidation within healthcare, right? So you have these huge hospital systems buying up all these different practices and smaller hospitals. And a lot of these hospital systems also have their own insurance. So they're, you know, people who get their insurance are on tiers as far as, oh, you can only see our provider. Or if the doctor within that health system wants to refer somebody outside because the exact person they need to see isn't within their system, it's very difficult, nearly impossible anymore to be able to do that. Um, so I see this as a barrier that's going to become even more of an issue in the future.
Yeah, it's so some patients may say, well, also it costs me a lot of money to get the health care that I need, and telemedicine may or may not be covered by their insurance program for now. But probably in the future, it will be more and more covered. And as it's being more accepted and as it's being understood that telemedicine is going to be a beneficial thing for the future. So patients should look forward to their insurance companies approving telemedicine in the future. Um, and they shouldn't be afraid to submit costs for telemedicine to their insurance companies at this time because it's pretty well accepted at this point. And and additionally, just paying for a visit may actually be cheaper than going and paying a copay for a specialist or plus a copay for therapy plus copay for this and that, MRI and everything, and maybe just paying for a visit really is not going to be such a bad thing for a patient when they can really stay home or not take a half day off of work and things like that.
Well, yeah, when you think of everything involved, right? So again, I go back to because we see it all the time. Somebody with a herniated disc, right? Whether they're, 40, 50, 60 years old, they were working outside or lifting something or awkwardly bent over or even perhaps a sneeze. And then they get this sharp back pain going down the leg a few days later. They might see a few providers. If they see one or two specialists, there's at least a $40 copay. They might go to 6 to 10 sessions of therapy at $40 a pop, and then get an MRI to kind of confirm what we already know. They're already out a couple $100s. Where one visit with a specialist through a telemedicine platform who deals with this all the time can direct them with a good home-based exercise program, and a lot of those individuals will get better,
Yeah.
right? And you don't necessarily need all those other steps, right? You don't need an MRI to confirm lumbar disc herniation if it smells like one, it looks like one,
Yeah.
and there's no concerning red flag signs or symptoms. I mean, it is one, right?
Yeah. Yeah. Exactly. I think that's a great example. We could come up with lots of similar examples, but I think the goal overall here is we hope that telemedicine can be very beneficial for patients, and especially the patients dealing with pain who we see all the time in our offices. We hope that they can get a similar benefit from a telemedicine program that will provide lots of education for them on how to manage and get better from their condition. Um,
I mean, I would agree with that. I know we were uh, kind of hit on a bunch of different topics today,
yeah,
but and we were kind of all over the place. But I know future talks and future episodes, we're going to kind of dive into specific conditions and issues with management of our pain patients, and we'll get into kind of the nuts and bolts and weeds with things detail. But for today, I know we wanted to kind of highlight a few different things that have been frustrating to us, to say the least, especially as we care for these patients every day.
yeah, for sure. We're definitely going to get into a lot of specific conditions and, hopefully offer some very useful information for patients in the future for many years to come.
That's right. I think that's a great goal. So
Yeah.
appreciate
All
your
right.
time today, Dr. Bonner.
Yeah, good talking to you. We'll talk
Have,
soon.
have a good day.